So I am the outlier. I am not the CMU connection, but that's okay, because I have purple hair, so it'll be fine. All right, so I'm going to be talking with you today about a platform we're developing called SystemD, which, as Alec mentioned, is how we're applying multimodal psychophysiology to mental health. So we've heard a lot of this already today, but I do want to level set us a little bit in terms of the clinical challenges around mental health. So healthcare providers, we know, often have limited time with their patients, which is going to be affecting their diagnostic speed and accuracy, and they have very little guidance in terms of selecting what treatment for what patient. Patients often are limited in their awareness and access to mental health care, and depending on how complicated their etiology is, they might have to go through a number of treat and repeat cycles, which is obviously going to affect outcomes. And the healthcare system, as well as we've heard this morning with some other statistics, is really expensive. There's going to be a lot of short and long-term costs around mental health, and obviously that's going to affect outcomes as well. So we can summarize that with this problem statement. The diagnosis of mental health problems lacks accuracy and precision and does not result in the most effective treatment selected. So what can we do about that? So we're approaching this from a quantitative biomarker approach. And I think of biomarker really broadly, so not just a blood biomarker, but it can be things like physiology and behavior. And if we think about the performance of these biomarkers with respect to sensitivity and specificity, we have a plot like this one. So we had sensitivity along the x-axis, so identifying those with the condition, and specificity along the y, identifying those without the condition. I've highlighted here the 90% threshold for both of those. We're aiming to be above that point for clinical adoption. There's no tool that's going to be 100% accurate in any case, but if we can be above 90%, that's going to provide some real clinical utility. So if we think about how clinicians do with respect to that, these are two data points that represent two meta-analyses looking at non-psychiatric clinicians. These are primary care physicians or just general physicians here, and looking at how well they diagnose major depressive disorder. So you can see that they're doing pretty well identifying those who don't have depression, so they're pretty high in specificity, but pretty low on sensitivity, so they're missing the people who do have depression. So this is just to level set us here in terms of how current clinical practice works with primary care physicians. So we can think here about a number of different types of biomarkers that we can get pretty non-invasively and pretty easily. So these are things like respiration, pupil diameter, electrodermal activity or skin sweating, and voice. So we can see the data points spread out here, and we see a promise with several of them. The key point here is that there's no one measure that's going to get us there, but we are seeing some promise. These data sets used archival data. Some of them were inpatient populations, and some were outpatient populations. So we've got quite a bit of diversity in terms of patient populations and how well they were doing with these measures. Similarly, we can look at things like blood, MRI, and fMRI. So we have some data points here for those measures as well. And again, we're seeing a lot of promise with many of these. However, these are going to be things that are going to be complicated to get. They're going to be time-consuming, they're invasive, they require specialized equipment and lab space, and it's not going to translate to a point-of-care setting very easily. So taken together, we can see all these points up here at once, and we can again see that there's no one measure that's going to get us there. We're making the case here for multimodal fusion, because we're seeing a lot of promise with these individual modalities, but again, no one measure is getting us all the way there. So what can we do about it? Well, we at Draper are developing what we call SystemD. This is a system with sensors to evaluate mental disorders, and it's a psychophysiological-based system designed to provide multimodal, objective, quantitative indicators of mental health. We've conducted 3 proof-of-concept studies with this platform, and I'm going to step you through 2 of them. So we've done 2 with PTSD and 1 with MDD. I'm going to walk through the PTSD ones. And at the end, I'm going to leave you with a video that will show you where we think this system can go in terms of providing treatment across the continuum of care. So our first study I'm going to go into was looking at PTSD diagnosis in combat veterans. This was a study we did a couple of years ago looking to see if we can use these objective physiological measures to assist in the diagnosis process. It's a little bit circular in that we're using the clinical interview and DSM scores as the ground truth, but that is what current clinical practice is, so that's what we did as well. We collected a number of different measures: electrodermal activity, electrocardiogram, respiration, and peripheral vasomotor activity. I'm going to be focusing on the top 2. And then we had a 4-part protocol. There was a baseline rest period. We did some startle response, emotionally evocative images and sounds. And then the bottom part was what I'm going to focus on. So a lot of the work in this area has been focused on idiographic or personalized stimuli specific to your particular trauma. We were looking to see if we could use something that was non-idiographic that might generalize more easily to a point of care setting where you don't have as much time to generate the stimuli. So in our study, we used VR videos, and in this case, we programmed in stimuli of increasing intensity. So the first one was a thing like a helicopter flying overhead, and the last stimulus was an insurgent running at you while shooting a weapon. This is a quick snapshot of our sample. We had 58 subjects spread across 3 groups. We had a control group, a trauma group with no PTSD, and a PTSD group. All folks in the trauma and PTSD groups had to have combat-related trauma, so getting in a bar fight while deployed did not count. And I give that example because we had one, but that was not inclusion criteria. We matched on age and gender, so these are all males, around 30 years old, mostly single, but we did have some diversity in terms of employment status and income. So this plot is showing the relationship between interbeat interval and PTSD severity. Interbeat interval is the inverse of heart rate, so higher values indicate a lower heart rate. So in this example here, we see a negative correlation showing that people with more severe PTSD tended to have a higher heart rate. So that lower IBI indicates a higher heart rate. This is what we'd expect given the etiology of PTSD, but it was assuring that we did see what we were hoping to see there. This is one of our key take-home findings. So participants watched 2 VR videos. The order was counterbalanced and all of that. But we were looking here at the reactivity of the 3 groups across the stimuli of interest that I mentioned before. This is skin conductance data, so how sweaty their hands are. The control group are represented by triangles, the trauma group by squares, and the PTSD group by circles. The key take-home here is that the control and the trauma groups habituated across videos, so the reactivity was less for the second video as compared to the first, but the PTSD group did not habituate. They showed equal reactivity across the 2 videos. And finally here, looking at some classification accuracy. So from the VR videos, we extracted skin conductance and IBI variables, and we submitted those to a linear discriminant analysis, and these are the classification results that we saw. So we were able to correctly predict 82% of the trauma people and 94% of the PTSD folks, with an overall percent correct of 87%. So we're well above chance here, and if you think back to how primary care physicians in terms of diagnosis, we're doing pretty well there as well. So the second study I'm going to step through is a treatment monitoring study that we did. This was a pre-post study, so folks went through the same protocol before and after a week of PTSD treatment. The protocol had a couple of parts. We did the standard clinical interview to confirm their diagnosis. We did the CAPS, a number of self-report questionnaires to get at things like PTSD, depression, anger, and resilience. The stimulus presentation had 4 parts, very similar to what you saw before. So we had a baseline. This time we made them do mental math, which is not very much fun if you have to do mental math. We also had them look at emotionally evocative images. And then the key part I'm going to focus on now is emotionally evocative scripts. So in this case, we used a script-driven imagery protocol. Script-driven imagery is where we tailor a script to you, to your individual trauma and your individual issue. So it takes a little bit of time because we have to get the information from you, write up sort of a standard length script, and then we record it to play it back to you during the protocol. So participants heard 4 scripts, 2 individualized and 2 standard, and of those, 1 was neutral and 1 was trauma-related. Sensors were similar. We got respiration data, cardiac data, skin sweating, and pupil diameter as well. This is a quick snapshot of our demographics. It was a really small study. We had 11 participants, mostly female, mostly Caucasian, but we did have a range of PTSD severity. This is a quick snapshot of electrodermal data for 1 person. So this is skin conductance data, how sweaty their hands are. Along the x-axis, you see the 4 parts of the script-driven imagery protocol. So there's roughly a 30-second baseline where they're just resting. There's a 30-second portion where they're listening to the script, so they're actually hearing it over headphones. Then they're asked to imagine them again in that situation, so reliving it. That's the imagine portion. And then a 30-second recovery period where they're, again, going back to baseline. We have 2 sets of lines here for pre and post. So you can see here we're seeing a marked decrease in reactivity pre to post. So this suggests, one, that the therapy was effective, because we are seeing lower reactivity, and two, that we can actually assess that therapeutic progress with these measures. So we also looked at the relationship between clinical change scores and the physiology. So we see here a correlation between the PTSD checklist scores and intermittent interval or heart rate data. And we see a nice correlation here showing that folks who had a pretty large change in their clinical scores also showed a large change in physiology. So our results show promise. What's next? Well, a couple of call-outs to you all. So we are seeking clinical champions and partners to facilitate more data collection. I'm very data hungry. I always want more data. We're looking for more heterogeneous samples, more disease states, and more therapeutic regimes. And in parallel, we're using feedback from clinicians and researchers to guide what the form factor for this system might look like. It's often helpful to have a thing in front of you. You can say, hey, here's the thing that we're building, and here's how we think it can be used, to show clinicians and researchers how it might fit into their workflow. So we've been working with a company called Radius Innovation and Development, to explore concepts for what the system can look like and how it can be used across the continuum of care. So I will leave you with a video that shows the system concept. And if I have a mouse, I will show you the video.
That's where SystemD comes in. SystemD is a quantitative and objective diagnostic support and monitoring tool that uses sensors to evaluate mental health. SystemD uses multimodal physiological and behavioral indicators to measure the patient's heart rate, EKG, skin sweating, and pupil diameter and eye movement. It also provides non-idiographic audio and visual stimuli to elicit emotional response. This allows for assessment of the physiological correlation of emotions and behavior, and augments current clinical practice and evaluations with the ability to be applied across the continuum of care. SystemD works early in the cycle to help pre-screen patients by capturing patient data in the wild to record event triggers. The key value is during the diagnostic support phase, where data are used in conjunction with clinical interviews to help validate diagnostic codes. The system supports clinicians in the selection of the best treatment by providing key insights that guide therapeutic and RX decisions. SystemD can also help patients after office visits with treatment monitoring, which offers a reliable, evaluative tool for monitoring patient progress over time. SystemD has the power and flexibility to add objective diagnostic support to clinicians, adapt to current clinic workflows, and support patients through the entire continuum of care. For the first time, we will be able to offer clinicians objective and quantifiable indicators, help patients access and get more effective and efficient diagnoses and treatments, and enable awareness, access, accuracy, and affordability in mental health. SystemD empowers your clinical care by revealing more.
Thank you.